Welcome to the deep dive.
Great to be here.
Today, we're really digging into a specific topic based on the materials you send over veterinary texts about Wolff-Parkinson-White syndrome, WPW for short, in dogs and cats.
Right. It's quite a specific electrical issue in the heart, not just a fast beat, but, well, a kind of short circuit.
Exactly. And that's our mission today. Using these sources, pull out the key stuff for you. We want to get our heads around what WPW actually is in pets, how it affects them.
How vets figure it out, diagnose it.
And critically, what the options are, what can actually be done. Think of it as us extracting the essentials from your research pile.
Okay, so let's get into it. Animal hearts, electrical signals. It's very fascinating stuff, actually.
Okay, so let's start at the beginning, based on these texts. Ventricular pre-excitation. What is that, fundamentally?
Okay, so pre-excitation, it just means that a part of the main pumping chambers gets the electrical go signal early, like sooner than it should.
Because normally there's a very specific route, right? Starts in the SA node, goes across the atria, then hits the AV node.
Yeah, and that AV node bit is crucial. It causes a slight pause, a delay.
Like stopping at a traffic light.
Exactly like that. It lets the atria finish squeezing blood into the ventricles. Then, after the pause, the signal zips down the normal pathways, the Wolff-Parkinson system, to make the ventricles contract altogether. It's all about timing.
But with WPW, something messes up that timing. The sources talk about an accessory pathway.
Or a Kent bundle. Basically, there's an extra electrical connection, like a little muscular bridge that wasn't supposed to be there.
And it bypasses that AV node traffic light.
Precisely. It creates a shortcut. Now, just having that shortcut, seeing that pre-excitation pattern on an ECG, that's one thing. But WPW syndrome, that's when you have the shortcut, plus the animal gets these bouts of really, really fast heart rhythms.
Often a specific type, right? Paroxysmal supraventricular tachycardia.
Yeah, exactly. SVT. That's where the real problems, the symptoms usually come from.
Okay. So if that's the problem, how do vets actually see it? You mentioned the ECG, the electrocardiogram.
The ECG is absolutely key. It's like listening in on the heart's electrical chatter. It's how you diagnose this.
And even when the heart's beating normally, if that pathway is there, the ECG looks different. The sources highlight a few things. First, a short PR interval.
Right. The PR interval measures the time from the atrial signal starting to the ventricular signal starting. It includes that normal AV node delay, so if it's short.
Like the sources say less than 0.06 seconds in dogs, less than 0.05 in cats.
Yeah, if it's that short, it tells you the signal is taking the shortcut, skipping that delay.
Okay. Then there's a widened QRS complex.
The QRS shows the ventricles activating. It looks wider because part of the ventricle muscle is getting activated early and maybe a bit more slowly through that accessory pathway muscle, while the rest gets activated super fast through the normal system. It sort of smears out the signal.
The sources give numbers for that too, based on size.
Yeah, 0.05 is for small dogs, 0.06 is for large dogs, 0.04 is for cats. Those are the rough guides mentioned.
And then the really distinctive thing, the thing you showed me in the diagrams from the sources, the delta wave.
The delta wave. Yes, that's the classic sign. It's like a little slur or a notch right on the beginning part of that wide QRS.
What does it represent?
It visually represents that initial, slightly slower activation of the ventricle muscle happening via the accessory pathway before the main fast signal arrives through the normal route. It's the signature of pre-excitation.
Got it. So that's the picture during a normal rhythm. What about when things go haywire? During a WPW syndrome episode?
Oh, that's when it gets really dramatic. The heart rate can just take off. We're talking incredibly fast.
How fast? The numbers in the sources seemed, well, unbelievable.
They are pretty shocking. Dogs often over 300 beats per minute. And cats.
Yeah.
Cats can get close to 400, even 500 beats per minute sometimes.
500. How can the heart even fill with blood?
It barely can. That's why it causes symptoms. And on the ECG during these episodes, things look very different. The P waves, showing atrial activity, are often just lost, buried in the rapid QRS complexes.
And the QRS itself, does it still look wide with the delta wave?
It can vary. Sometimes it looks relatively normal, sometimes wide with delta waves, sometimes just plain bizarre. It depends on exactly how that electrical signal is looping around using the accessory pathway and the normal system.
The texts mentioned often seeing a one-to-one conduction if you can make out the P waves.
Yeah, meaning for every atrial beat, P wave, there's a ventricular beat, QRS. It suggests the rapid rhythm is being driven from above the ventricles involving that loop.
Okay, so we know what it looks like. Let's talk about why. Why does this accessory pathway even exist? The sources say it's congenital.
Yes, animals are born with it. It's basically an error in how the heart forms very early on. There's supposed to be this fibrous insulating layer, the annulus fibrosus, separating the top chambers, atria, from the bottom chambers, ventricles.
Keeping the electricity flowing only through the proper route, the AV node.
Exactly. But in WPW, that insulation didn't form completely. There are gaps, leftover bits of muscle tissue connecting the atria and ventricles where they shouldn't be. That's your accessory pathway.
Just a structural mistake from development, and often idiopathic.
Yeah, meaning in most individual cases, we don't know the specific trigger for that developmental error. It just happens.
And these pathways, they're not just passive wires, are they? They have properties.
Right. The sources mentioned they can conduct electricity in an all or none way. And critically, they can conduct in different directions. Some only conduct from atria down to ventricles. That's called anterograde. Some only conduct backwards from ventricles up to atria retrograde. And some can do both.
And that ability to conduct in different directions is what sets up those fast rhythms.
Absolutely. It creates the possibility for a reentrant circuit. Imagine the signal goes down the normal AV node path, activates the ventricles, but then finds the accessory pathway and travels backwards up to the atria.
Re-stimulating the atria, which then sends the signal back down the normal path again.
Precisely. It gets stuck in this loop, going round and round, triggering incredibly fast heart rates. That's the most common mechanism called AV reentrant tachycardia, or AVRT.
Okay, but the sources seem particularly concerned about one scenario, a really dangerous one.
Yes, this is probably the most critical point regarding risk. If an animal with WPW develops atrial fibrillation, AFib, or atrial flutter.
Which is already a chaotic, super fast rhythm in the atria.
Right. Normally, the AV node acts like a gatekeeper, blocking a lot of those chaotic signals from getting down to the ventricles. But if the accessory pathway can conduct those signals very quickly downwards anterograde.
That's bypasses the gatekeeper.
Exactly. And you get this incredibly fast, dangerously irregular ventricular rhythm because the pathway just lets almost all those chaotic atrial signals through. The source is very clear. This situation, rapid AFib conducting down the accessory pathway, can degenerate into ventricular fibrillation, which is fatal if not stopped immediately.
That's a serious risk. Are these pathways ever linked to other heart problems?
Sometimes, yes. The sources mention associations. In dogs and cats, things like atrial septal defects, ASD, holes between the atria. In dogs, sometimes tricuspid valve dysplasia. And a really notable one, especially in cats, is an association with hypertrophic cardiomyopathy, HCM.
So finding those other issues is important.
Definitely. It affects the whole picture, the prognosis, the treatment plan.
And any hint of genetics. Like in people.
The sources do briefly mention that possibility. They note specific gene mutations linked to WPW in humans, suggesting, yeah, there's likely a heritable component in at least some animal cases too.
Okay, so we have the cause, the mechanism, the ECG signs. What about the animal itself? What might an owner actually see?
Well, first, a key distinction from the sources. If the animal only has the pre-excitation pattern on their ECG, but never gets those fast rhythms, they're often totally fine, asymptomatic.
You wouldn't even know they have it without that ECG.
Pretty much. But if they have WPW syndrome, meaning they do get the episodes of tachycardia, then you absolutely see signs.
And what are the big ones?
The symptoms are all related to the heart beating too fast to pump blood effectively. So the most dramatic sign mentioned is syncope that's fainting or collapsing suddenly, just passing out.
Because the brain isn't getting enough blood.
Exactly. Owners might also feel the heart racing palpitations.
Yeah.
Or notice their pet gets tired really easily with exercise intolerance.
Or just general weakness, lethargy.
Anything else. Less common signs.
If the fast rhythm goes on for a long time, the sources mention it can sometimes lead to signs of heart failure, like difficulty breathing or maybe coughing. But syncope and weakness are the more typical acute signs. And we have to mention, even though it's rare, the most devastating outcome is sudden cardiac death. Usually linked to that scenario we discussed, rapid AFib conducting down the pathway, leading to ventricular fibrillation.
Right. So putting it all together for a diagnosis, how does the vet team nail this down? Well, we keep coming back to it, but the ECG is number one. Seeing that classic pattern, short PR, delta wave, wide QRS during a normal rhythm points strongly to pre-excitation.
And catching the fast rhythm itself.
Catching the actual tachycardia episode on an ECG, especially if it looks like that reentrant SVT involving the pathway, confirms the syndrome.
What about just listening or examining the pet?
On the physical exam, the vet might hear that incredibly fast heart rate if an episode is happening. and they might hear a heart murmur if one of those associated conditions like an ASD or valve problem is also present.
What other diagnostics are crucial, according to the sources?
Echocardiography, the heart ultrasound, is listed as essential. You really need to look for those underlying structural problems we talked about. Does the cat have HCM? Does the dog have an ASD? That information is vital for prognosis and treatment.
And what if the episodes only happen now and then? You might miss it on a quick ECG in the clinic.
That's where Holter monitoring comes in. The animal wears a little vest with an ECG recorder for 24 hours, sometimes longer. It's brilliant for catching those intermittent tachycardias, seeing how fast they get and how often they occur.
The sources also mention something called an electrophysiological study, EPS. Sounds specialized.
It is very specialized, usually done by cardiologists. They guide special catheters with electrodes inside the heart to map out the electrical signals precisely.
Why do that?
Its main purpose is to pinpoint the exact location of the accessory pathway, or pathways. This is often done right before they attempt a curative treatment, like ablation.
And just routine blood tests.
Usually normal in WPW itself, but the sources say it's still important. Rules out other things, checks general health, and critically, checks organ function, like kidneys and liver, especially before starting long-term heart meds.
The text briefly mentioned telling WPW apart from other things.
Yeah, differentiating. Like, other things can cause a short PR interval, maybe fever or hyperthyroidism, but those don't have the delta wave, which is key for WPW pre-excitation.
And telling the WPW tachycardia apart from other fast rhythms.
Often relies on seeing that underlying WPW pattern on the ECG when the heart is in normal rhythm, and distinguishing a wide WPW tachycardia from VT, ventricular tachycardia, can be tricky, but looking at the whole clinical picture helps.
Okay, diagnosis confirmed. Let's talk treatment based on these sources. What are the options?
First, that important point again. If it's just the ECG pattern, no symptoms, the sources generally say no treatment is usually needed, maybe just monitor.
But if they are symptomatic, having those WPW syndrome episodes,
Then you need to treat. For an acute emergency, when the heart is racing dangerously fast right now, the goal is to stop it.
how?
Sometimes vagal maneuvers like gentle pressure on the eyes can work, briefly, but usually it's IV medications. The sources list several. Lidocaine, amiodarone, sotalol, and procainamide gets a special mention,
Why procainamide specifically?
because it's noted to be good at slowing conduction over the accessory pathway itself, which makes it a potentially safer choice if the rapid rhythm is atrial fibrillation conducting down that pathway.
And the most effective emergency treatment mentioned.
That would be direct current cardioversion, an electrical shock, basically, delivered under anesthesia. It's very effective at stopping most of these severe tachycardias fast.
Okay, that's the emergency. What about long-term, preventing future episodes?
That usually involves daily oral medications. The sources mention quite a few. Sotalol is often a first choice, procainamide again, flecainide, maybe diltiazem, or atilol.
Now, this seems like where we hit that really crucial warning in the sources about certain other common heart drugs being potentially dangerous here.
Yes, this is absolutely critical to understand about WPW. The texts strongly caution against or say you absolutely should not use drugs like digitalis, digoxin, verapamil, and often beta blockers like propranolol or atenolol or diltiazem in many WPW situations.
Why? These are standard drugs for other heart rhythm problems. Why are they bad for WPW?
Because their main action is to slow down the signal going through the normal AV node. Remember, the accessory pathway bypasses the AV node. So if you block the normal safe route with these drugs, but the accessory pathway doesn't get slowed down much, well, you've potentially made the accessory pathway the main or only fast route for signals to get to the ventricles.
Oh.
Exactly. And the sources hammer this point home. If the animal then goes into atrial fibrillation, instead of the AV node blocking most of the chaos, the accessory pathway can just conduct all those super fast signals straight down, leading to incredibly rapid ventricular rates, maybe even VFib.
So you're blocking the brakes but not the accelerator bypass.
That's a great way to put it. That's the danger.
Helen, didn't the sources also mention propranolol and atenolol sometimes being used, especially in cats? That sounds contradictory.
It does, and highlights just how complex this is, as shown in your source material. The general warning is real and important, but the specific effect can depend on the individual pathway's properties. Does it conduct fast or slow? Only one way. And maybe cats respond differently, or the specific type of arrhythmia matters. It means treatment isn't a cookbook. It needs careful assessment by someone who really understands the electrophysiology.
Okay, that makes sense. It's nuanced. So if an animal is managed long-term on appropriate meds, what's the outlook?
The sources suggest many can do well. They can have a good quality of life on lifelong medication. But, breakthrough episodes can still happen, or they might get side effects from the drugs. So the prognosis is often called good to guarded.
Is there anything more definitive? A potential cure?
Yes. And this is exciting. The sources talk quite a bit about radiofrequency catheter ablation, RFCA. It's described as the definitive or potentially curative option.
How does that work? You mentioned the EPS mapping.
Exactly. First, you do the EPS to find the exact spot of the accessory pathway. Then, using a special catheter, you deliver radiofrequency energy, it's like targeted heat, right to that tiny area of abnormal tissue.
And that destroys the pathway.
It ablates it, yes. Destroys it, breaks the circuit.
So you actually fix the underlying electrical problem.
That's the goal. And the sources highlight the big advantages. Potentially curative, no more daily meds, and high success rates are the aim, aiming for 90% like in humans.
What are the catches?
Well, it's highly specialized, needs expert cardiologists and special equipment, so it's not available everywhere. It's also expensive, needs anesthesia, and like any procedure, carries small risks, maybe damaging the normal conduction system, very rarely perforation.
Anything else mentioned for management?
Just reinforcing common sense, things like limiting activity during episodes, and really stressing client education, making sure owners understand the condition, what to watch for, and the importance of treating any other heart disease present too.
So looking long-term, how are these animals monitored? And what's the bottom line on prognosis?
Monitoring is key. Regular vet visits, definitely repeat ECGs, maybe follow-up Holter monitors to check if the treatment is working well over time.
And repeat echoes.
Yes, serial echocardiograms if there's underlying structural disease to track. And routine blood work to monitor for any medication side effects. And prognosis, as we've sort of gathered, really varies. It depends entirely on the situation.
So just the ECG pattern, no symptoms.
Excellent prognosis, the sources say. They might live their whole lives without trouble from it.
Symptomatic, but managed okay on meds.
Generally good to guarded. Many live well, but control isn't always perfect, and side effects are possible.
And if they have successful ablation?
Prognosis is generally considered excellent then, often seen as cured.
But the sources do circle back to that underlying risk, however small.
They do. It's important to remember that WPW, by its nature, carries that potential for really dangerous, life-threatening arrhythmias, especially if AFib develops and the pathway conducts it rapidly. That pathway-AFib interaction is the core danger highlighted.
Okay, let's try a quick wrap-up of the key takeaways from these sources then.
Sure. WPW is congenital, an extra electrical pathway bypassing the AV node.
Seen on ECG as pre-excitation short PR, delta wave, wide QRS, and it can cause episodes of very fast heart rates, the WPW syndrome.
Symptoms are usually things like weakness, collapsing, or fainting, maybe exercise intolerance, all due to the fast rate. Diagnosis, heavily reliant on the ECG, backed up by echo for structure, Holter for intermittent episodes, and sometimes specialized EPS mapping.
Treatment involves managing acute episodes. Then long-term options are usually meds with those important warnings about certain drugs or potentially curative catheter ablation.
And prognosis is variable. Excellent if asymptomatic, good to guard it on meds, often excellent after a successful ablation, but always with that small underlying risk of severe arrhythmias.
Wow, we've definitely gone deep here, from the nitty-gritty of delta waves to fainting spells and ablation, all pulled from this specific set of veterinary texts you shared.
It really shows the level of detail involved, doesn't it?
Yeah.
Understanding these conditions isn't simple.
No, it's not. And it kind of makes you appreciate the complexity just humming along inside our pets, usually unnoticed.
Yeah, until something like this tiny extra pathway causes such big problems.
And understanding that detail is exactly how vets can step in and help animals that, can't just tell us, hey, my heart feels funny.
Absolutely true.
So maybe a final thought for you listening, sparked by this dive. Just how much hidden complexity is ticking away inside seemingly simple biological systems, and how critical is that deep specialized knowledge, like understanding one faulty electrical wire for making a real difference when things go off track.
Something to ponder, definitely.
Well, thank you for joining us for this deep dive into Wolff-Parkinson-White syndrome in animals.
Hope this exploration of the source material was useful for you.
We'll catch you on the next deep dive.